You're muted, Michelle.
Story of my life. I'm Michele Cox. I am the provider engagement specialist for Dispatch Health. I cover multiple markets throughout the country, and I typically work with providers to help lower their unnecessary ER utilization. So I'm really trying to help keep patients from having to go to the ER. I started Dispatch Health. I didn't start Dispatch Health. Sorry. I started working at Dispatch Health in April of 2001. So I've almost been here 2 years. I've started in Nashville and Knoxville in the senior space. So my heart is with our 65 and older population. I first learned about Dispatch Health after my granny got COVID in 2001, and she was refusing to go to the ER. And I had a friend who worked for Dispatch Health, and she said, let us come out, let us come out, let us come out. And Granny finally agreed, and we came out to see her, gave IV fluids, medication, really got her through COVID. Even did a follow-up appointment because she was refusing to go to the ER, and her doctor, because she had COVID, wouldn't let her come in. Granny is alive because of Dispatch Health. And so that's when I decided I wanted to work for them. My passion has been really helping all of the patients that we can reach stay out of the ER. So I'm going to share my screen. I'm going to turn off my camera so I can. Can everybody see my screen?
Yep.
Perfect. I want to start on some history about Dispatch Health, just so you understand our why. We were started by Dr. Mark Prather, who's a board certified ER physician, and PA Kevin Riddleberger. They worked together in the ER and noticed that patients were funneling through that really didn't need to be there. So UTIs, dehydration, migraines, and they were sitting for long periods of time because the ER is truly for those time-sensitive cases. And they were being pushed back because more time-sensitive and life-threatening cases were coming through. By the time they saw them, there was more wrong with them than when they walked through the door because they were sitting for so long. So they decided there's got to be a better way to do this. They partnered with the South Denver Metro Fire Department, and anytime it wasn't life or limb threatening or time sensitive, they would dispatch out with the fire department and ask the patient for permission to treat them in the home instead of going to the ER. We saw 400 patients in an 18-month period. We saved over $1 million in healthcare costs, but most importantly, we had zero adverse outcomes. And what we found was when you treat a patient in the home for those acute needs, when they can't get in to see their PCP, outcomes are much better than going to the ER. So we believe that home is where your health is. So we've got several different service lines within Dispatch Health. Right now, Northern Virginia has acute care only, which is our emergency room substitution. And so that's what we're going to really talk about today. So we do provide high acuity in-home urgent medical care. Now that's a really fancy way of saying we can do a lot of what the ER can do in your home instead of you having to go out. It's important to realize we're not here to take the place of your primary care doctor. In fact, I want you to call them first every single time, because that PCP has your entire roadmap of your health right there at their fingertips, and they are truly the best person to take care of you. What we want to be is the safety net. So on the weekends, evenings, holidays, when you can't get in to see your PCP in a timely manner. Friday afternoons are a great example, right? You don't feel good on Friday afternoon, you call in and there is no more appointments available. Make that appointment for the next week, and then you can give us a call to come out and bridge that gap over the weekend so you don't get worse. We're also not here to take the place of 911. That's for actual emergencies, such as those heart attacks and strokes, and those time-sensitive, life and limb-threatening situations are when you would call 911. So we're really proud of our NPS score. This is basically a patient satisfaction score. It stands for Net Promoter Score. The score goes from -100 to 100. The healthcare average sits at about 30, and our national average sits at 95. So the patients who utilize our services are really happy with the care that they receive. And then you can see here on this map, we have grown exponentially since our pilot back in 2013. We've been around for 10 years. But we have grown throughout the country. This map is probably not up to date because we've opened 2 markets since I had put this slide in, but we are now in 49 markets, and we're in 29 states. So let's talk about how we get care, and then we'll run through what that care looks like. So when you call in, this is not like calling 911. You're not going to call in and say Betty fell and then we're on our way. This is like walking into an urgent care. So you walk into the urgent care, you stand at the desk and you give your name, date of birth, your address, your phone number, your insurance information. We're going to collect that all over the phone. But instead of getting in your car and driving across town, you're doing it from the comfort of your own home. Once we get all of your demographic and insurance information, we will make sure that you are in fact in network with us, and then we will do a risk stratification. That's just a series of yes or no questions to make sure it's safe and appropriate for you to wait for us to get to your home. And then we obtain verbal consent. That's as easy as, yes, I want you to come see me, or yes, I want you to come see my husband or my mom, my dad. So you'll do that verbally over the phone, and then we'll give you a range of what time we'll be there. We're not going to hold you hostage like Comcast. Okay, we're going to give you a 3 to 4 hour period, and typically that's not a big deal because all you want to do is rest anyway. And so you'll know that we'll be there within a 4 hour period. Once we hit en route, you will get a text message that says, we're on our way. We should be there by 11:15. And then we'll give a call to you about 10 minutes before we get to your home, just so you're aware that we're going to be pulling in really soon. So I'm going to skip this right here because that's for physicians. Let's talk a little bit more about the risk stratification. So like I said, a series of yes or no questions depending on how you're feeling. We're trying to determine not only is it safe and appropriate for you to wait for us, but also is worst case scenario something we can even rule out in the home. So we're trying to make sure before we even put you on the schedule that you're going to the right place, whether or not we're coming to you or you're going to the hospital. When we finish that screen, we're going to screen you green, yellow, or red. Green means no red flags. We're going to give you an appointment. Yellow means that you said some things we need to dig a little bit deeper on. And so we're actually going to put a nurse on the phone to have a one-on-one conversation with you and really ask some pointed questions to make sure you don't need to go to the ER. A lot of times people say, dispatch health is so new, a new concept to me. I don't know if I should call 911 or if y'all can handle it. Give us a call. We'll walk you through it and make sure we point you in the right direction if we cannot take care of you. And then red means that you truly need to go to the ER. So just know when you call in, it's a 10-15 minute conversation with us that you get to do in the comfort of your own home. So when we come out as a team. So we typically have a lovely wrapped dispatch health car. So it's easy to know that we are at your home. We have an APP that is an ER or urgent care trained nurse practitioner or physician's assistant. And then what we call a DHMT, that's usually either an EMT, paramedic, or an MA. So they come out together. Every now and then you may have the APP virtual if you're not as sick, if you're more low acuity. but you'll have both of them taking care of you. There is an ER physician that will always be in our back pocket. So if we arrive on scene and things have escalated, or now you're presenting very differently than when you called in over the phone. In Nashville, true story, we had a patient that had a headache, but was also bit by a monkey. So our nurse practitioner said, we covered this in school, but I've never utilized that information. So let's just run through everything before I arrive on scene. We have seen some really wonky things going into patients' homes. And so it's really nice to have that ER physician in our back pocket. So let's talk real quick.
Michelle, before you go on, what was an APP?
That's an ER or urgent care trained nurse practitioner or physician assistant. So,
Okay.
A mid-level. I'm going to pause right here real quick because I want to talk about what if we get on scene and we realize you truly do need to go to the ER. Maybe you're so dehydrated we can't even stick you. So we will call 911. We stay with you until the rig gets there, and we are given a clinical handoff to that EMS team. So that way they are more prepared when they roll you into the ER. So we will stay with you. We're not going to say, you need to go to the hospital. Bye. We are going to make sure that we're there with you as you get into that rig. All right. So we do travel with a moderately complex lab. We are CLIA certified. That just means that we have a national accreditation for this lab. We can do rapid flu, strep, and mono test. We can do both COVID tests depending on if you're symptomatic or not, but also we can do a urinalysis right on scene. So if you feel like you have a UTI, we can do that right on scene in the comfort of your own home. We carry an I-stat, and that allows us to do PT-INRs, Chem8s, and lactates. If you have no idea what I just said, that's okay. It's a way for us to be able to see markers in your blood immediately while we're on scene, and that will impact how we treat you. So if we feel like your potassium's out of whack, we can check that. We can check your lactates to see if you're dehydrated. And then we carry a small pharmacy with us. We're giving those first dose medications on scene. So if it's 8 o'clock at night and you have a UTI, you don't want to get out and get that prescription. And actually, you may not be able to go pick up that prescription because the pharmacy may be closed at that point. So we're giving that first dose on scene so that way you're feeling better by the time your prescription comes your way. It's important to know that we stronger than Toradol, so we are not giving narcotics out from our teams. And then we work with mobile imaging for those medically homebound patients. So if you can't get out to get an x-ray, we can send the x-ray to you. It is important to realize that just because we have a moderately complex lab, it doesn't mean we are a mobile lab. So if you have PT-INRs that are checked weekly and for whatever reason you can't get out to have that checked, we cannot do that for you. We are truly an urgent care and we have to treat symptoms. If you don't have symptoms, we cannot come in and treat you. So just know that if you need routine blood work, that is not in our scope of practice. We can draw blood and send out to LabCorp if we suspect that certain things need to be checked, and then we will circle back with your PCP on that. All right. So these are our kits. Think about your 1950s doctor bags just on steroids. We are fully stocked, so we can see multiple patients for the same thing without having to go back to the office to restock. We have set up in an assisted living facility when the stomach bug went through the whole thing. We've seen a family of 5 for COVID because they couldn't get out. So we can see multiple people in one place. We have a general and ortho side. So that's where our medications are. We have braces, splints, immobilizers. We carry a material called orthoglass, and that is a casting material. So if you fall and you feel like you broke your wrist, you can give us a call. We can set and stabilize that bone fracture and send you into the orthopedic instead of having to go through the ER. Now, with that being said, if you fall and break your hip, we're probably going to send you to the ER, right? Because you're probably in immense pain and you're probably going to need surgery. So we will send you to the ER because that will give you the immediate care without you having to worry about waiting for us. If you fall and hit your head, we're also going to send you to the ER because we can't see if you have bleeding in your brain. You really need to go into the ER to have that tested with imaging. We have a GI UA kit, so we can change a Foley catheter. If you have a suprapubic catheter and your own supplies, we don't typically carry the correct French for that. So if you do have your own supplies and need help, we can come in and change that for you. If you can't produce a specimen for that UA, we can absolutely do a straight cath and get that for you. We can do enemas for impactions, and then we can, of course, send out that UA for culture to make sure we do have you on the correct treatment plan. We talked about the LAD part already. We have a laceration and wound kit, so we can stitch, staple, and glue. If you have a wound that seems to be infected, we can come out, we can change the dressing, we can clean up the wound, get you on an antibiotic. If you've created a wound, we can absolutely come out and treat that. We can bridge the gap. I love to joke that the wound care center does not answer their phone after noon on Fridays because they are just so busy. And a lot of people end up in the ER because they really need that wound checked out. We can avoid the ER now by calling us. We have an ENT, eye, and respiratory side, so we can treat ear and eye infections. We can pack and cauterize a nosebleed, and then we can do nebulizer treatments. It's important to know that we still cannot do nebulizer treatments for COVID. And also it does depend on the space in which we're administering that, which will all be taken into account before we administer that nebulizer treatment. We're super glad to have that back in our back pocket because COVID took that away for a little while. And then we do.
Do you carry non-penicillin based antibiotics?
I do believe so, because penicillin is a common drug that people are allergic to.
Okay, and we've got a couple of questions about insurance coverage. Are you going to address that later, or should I?
I am. Yep, I will. I will. Well, I'm going to pause after these next two things, and they can ask as many clinical questions as possible, and then we'll move on to the other things.
Okay.
So we do IV fluids. We don't just do IV fluids though. We do IV antibiotics, IV steroids, IV Lasix, as well as IV Benadryl. And when we do IVs, we stay with you the entire time. When we leave, there's no needle in your arm, so you don't have to figure out how you're going to get that out. If you need a second bag of fluids, we will absolutely stay. And then we also have a 12-lead EKG machine that will print out on scene if we need to check your heart. Now I'm going to pause. If you want to throw the clinical questions at me, I promise we'll get to service area, hours of operation, and insurance coverage here in just a minute, but let's talk about the clinical piece first.
Okay, first one is, what is PT-INR?
So if you are on a blood thinner, a lot of times they check your PT-INRs to make sure it's in a normal range. That way they can adjust your dosage.
Okay, you mentioned being able to send out an X-ray. Can you also do CT scans or MRIs or some equivalent kind of scan?
So a CT and an MRI you'll have to go to the hospital for. Yep, we can do an X-ray, and then there are capabilities of sending in an ultrasound. So if we feel like you have a blood clot and need to look at that, we can order an ultrasound that can come into your home.
Will you remove stitches from surgical incisions?
We can absolutely do that.
Okay, I don't see any other questions right now. So if you want to press on.
All righty. So the journey that you will take with dispatch is identifying that you need help because your PCP is not either available at the moment or it's weekends, holidays, evenings. And so you'll call in, you'll run through the onboarding process, which includes giving the access center your demographic information, your insurance information, and giving them verbal consent. And then we come out to your home and treat you. And then at the end, we send those clinical notes back to your PCP, or if you have a urologist or pulmonologist or cardiologist, and you want them to get these clinical notes too, we can send it to everybody in your care team. If you have home health, we can send the clinical note to home health. We want to create an all hands on deck approach. That way, everybody who takes care of you knows what's going on, and they may say, oh, I need to get her in so we can check some of the other things that I know could be going on. And we're also going to send that clinical note probably within 24 to 48 hours. So they're going to get it very quick. Our DHMT drives, so our APP can chart, and usually those clinical notes are done by the end of shift or the next morning.
Michelle, I have a question here. How would you deal with kidney stones?
That's a good question that I don't have an answer to. Let me text a friend real quick, and then maybe I can circle back to that at the end.
Interestingly, your chart here says that you do deal with kidney stones.
We do. I just don't know the treatment plan for it.
Uh,
Yeah. So I have texted a friend to see if I have an answer. We'll circle back when he texts back. So these are the common reasons we're called. So if you want to take a look at that real quick, this list is online at dispatchhealth.com. So you can absolutely find it if you want to come back to it later. I'm going to keep it up here so everybody can see it real quick. All right. What everybody wants to know. So we bill at the urgent care level. So just like you and I can walk into any urgent care and be seen, anybody can call us. When we go through the onboarding process, we will take your insurance and let you know if you're in network or not. One of the important things for you to realize is we will always ask for a credit card. We are a business, and so we will ask for that over the phone. If you are in network, you can decline and not give us the credit card. If you are out of network and you want us to bill for out of network benefits, we will ask for that credit card to be on file. We will not charge it the day of service. We will charge your insurance, and then when they get back to us, we'll send you a bill. You can call back in and say, hey, I got my bill for X amount of dollars. Will you charge the credit card you have on file, or I want you to use another credit card? And then if you are not in network, there is a self-pay rate of $275. So it's super cheap compared to some of the other places. And we will take payment over the phone before we come out. But Virginia has been one of our markets for almost 10 years. It was one of our markets that we opened after our pilot. And so the insurance, that's the in-network insurance list, is quite robust. just know that when you call in, we work with Medicare, Medicare Advantage plans. We work with United Healthcare and Humana and Blue Cross Blue Shield. Just know when you call in and you give your specific plan, because sometimes one plan is covered and one plan is not. When you give that information to us over the phone, we are going to check that prior to coming out to see you.
Michelle, I have a question here. Can someone set up an account in advance with all of that demographic and health insurance info so that if they're having a problem, they don't have to worry about digging out their insurance cards and, remembering all this stuff while they're under duress?
So no, mostly because your living situation can change, your insurance can change. We have to check all of that on the front end before we can come out to see you. But just know it's not going to be an hour of your time. We're going to be on the phone for about 10, 15 minutes. Any other questions on this?
Well, suppose somebody has a secondary insurance with Medicare and they can't find the card at the time they call. Can they say, hey, can I get back to you with that after the fact?
Yes, you can do that.
Okay.
And if you get the bill and realize you have a $30 copay and have found that secondary, you can call in and just have that added so they can bill the secondary.
Okay, thanks.
So if I look at my insurance card, I have what my copay is for a PCP and what my copay is for a specialist and what my copay is for urgent care and the ER. That should give you a really good idea of what to expect. If you don't know whether or not what your urgent care copay is, you can definitely call your insurance and say, hey, in the event I go to an urgent care, what would that copay look like? And they should be able to give you that information. But like I said, they've typically started putting it on the card so you have direct access to it.
Now, the costs that you've listed, is that for everything you would do during a visit, or is that just, that's what it costs to show up and whatever, medicines and bandages and whatever we use, those get billed in addition?
Nope. So when we bill at the urgent care level, we're just billing that code. That's everything we do. So if we come out and we stitch you up, we do a UA, give you an antibiotic, we set and stabilize a bone fracture and pack and cauterize your nosebleed. We do all of that. It's still the same. The only time you'll be charged anything different is when we have to send an x-ray or ultrasound out, and the company that comes out will have to bill themselves. And then if we decide that you need extra labs drawn, we will send that and LabCorp will bill. So those will be separate charges, but anything else will be absolutely in that urgent care copay.
Are you covered by Medicare Part A or Part B or both?
So Part A is a hospital,
right?
And home health coverage. So we would be billing Part B. And I do want to answer the kidney stones. So we would be pushing fluids, IV fluids if needed. Flomax and Toradol is how we would treat those kidney stones.
And then you'd make a decision, do they need to go to the hospital or have any follow-up care?
Yep, we would definitely want to tuck you back in with your PCP. If for whatever reason you couldn't get back into the PCP, we will do a follow-up in 2 to 3 days. So we have done that. Sometimes your PCP goes on vacation and there's no bandwidth within the group that they're in. We just want to make sure that you don't end up in the ER if you don't need to actually be there. All right. So here's our map. So I know that this looks a little wonky. It is zip code based, which makes me question a lot of things about how we do zip codes. But the map can be found online. There is a list of zip codes. So if you want to go there and look at that list of zip codes to see if you are in there, if you're on that line. We do have another market right across in Washington, D.C., which Carolyn and I realized. So if you're right there on that border and you feel like maybe you might be on the DC side, then you can pull up that DC map and look at those zip codes. And I want everybody to write this down. I'm going to give everybody the ability to grab a pen and a paper. To request care, you're going to call 571-348-4973. So go ahead and plug that into your phone. But that's the number you would call in and say, I'm not feeling real well. I'd like you to come out to see me, and we'll start that onboarding process. And we are open from 8 o'clock in the morning until 10 p.m. Now, we do want our clinicians to come back to the office at that 10 p.m. mark. So we're probably taking our last appointment around 9 o'clock. But we're open 365 days a year. So we are open on holidays, weekends, after hours, and there is no extra charge for those holidays and weekends and after hours. We're actually pretty busy on those holiday days. Any questions about this?
We had a request for you to repeat the phone number, but
Yeah, I can do that. And if you want to throw it in the chat too.
yeah, we just did.
Okay, perfect.
But Pat or whoever, if you can't see the chat, it's 571-348-4973.
Any questions here? And that's it.
Okay. Question here. What happens after hours? And you just call the ER or?
So what we found is in the event that, I'm trying to unshare my screen. There it is. Okay. In the event that sorry, my mute button just went on. In the event that you need help after hours, we've seen that either it's really a true emergency if you can't wait until 8 o'clock that next morning, or we've had some drug seekers reaching out. So that's why we've closed out that 10 to 8 in the middle of the night. So if it's after hours and you don't feel like you can wait until the next morning, then it probably is truly an emergency.
Question here. Did you say that the charge for uninsured is $275?
Correct.
Okay. Are there any popular insurance plans in this area that are not in network?
That's a question I can't answer. It changes almost weekly what we're in network with. So the best way to find out is when you are sick, calling in and asking them to run it. Because I could tell you something today and in a week it may be different. We may have added another insurance. And so I don't want the healthy people here on the call to think that they're not in network because they're sick in 2 months and don't think so because I said it today.
Okay. Somebody here says they still have a question about pain. So if you want to unmute yourself and ask it or put it in the chat. And the next question is, do you have a website?
Yep, we have a portal that when you get your bill, you can go there and pay online. My husband had COVID over Thanksgiving and his doctor retired. And so I had our team come out to see him and I got the bill and paid online.
And Steve just put in dispatchhealth.com for anybody that wants to go and check out in more detail what you're doing. Question here, how has Medicare adapted to this model of healthcare?
I mean, I don't know that they have adapted. I know that they have seen value in it and cover it. There's a lot of mobile services that are coming down the pipeline and that are being created because there's such a need for it. I think that Medicare values that. That's why we have a Medicare number.
Okay. How many teams are there in the Northern Virginia area?
Whew. I want to say, and actually, let me look it up real quick, and I can tell you how many cars they have. It looks like we have 2 cars. One runs from 8 o'clock in the morning until 6 o'clock in the afternoon, and then one runs from noon to 10. So we have 2 cars overlapping in that really busy period. We do have an optimizing team at headquarters that will look at the call that comes in, where the address is, and then where our cars are. So they figure out, okay, we'll put it on this car because they can get there faster. And then they're always looking at, oh, we had to do another bag of IV fluids at a patient's home, and this car can take on this patient so they can get there faster. So we have a whole team that's looking at a bird's eye view of what's going on and shuffling things around to make sure that we're doing things timely.
How do you deal with falls without apparent injury? So somebody's had a bad fall, but they haven't broken their wrist, but they're concerned about it.
So, few things. If you've fallen and can't get up, you want to call 911 and have the fire department come and get you up first, because I don't want you on the floor for the 2 hours it may take for us to get there. And then once you're off the floor and comfortable, you can give us a call and say, I'm hurting everywhere, I've fallen. I'm not sure if I broke something or not. We'll run through that wrist strat to make sure you don't truly need to go to the ER, because if you hit your head, we're definitely sending you. And then we'll come out and then just treat you based off of how you're feeling, what your symptoms are.
How many calls do you typically handle in a day?
That's going to depend on the day and the season. When respiratory ramps up, we have a lot of calls during the day. Our access center covers all of our markets. So we may have more calls in one market one day and another in another day. So that's a hard question to answer. I will say we typically see about 9 patients per car a day, 7 to 9, depending on how sick someone is. So we have the capability in Northern Virginia to see about 18 patients a day right now.
As I listened to you talk, I took my husband to the urgent care for flu about 3 weeks ago, and I realized I should have called you.
Oh,
He would have been much more comfortable.
yeah. Sitting in the chair in the urgent care is not fun. No, and I've actually I called them out to treat my son for strep throat in his bed. It's like he was able to just sleep in his bed and wait for somebody to get there. And I was able to work and clean my house and all the things that I needed to do. My day wasn't disrupted either.
Yeah, good point. We were like 4 or 5 hours in the clinic. Mike, you have a question?
I do. I have made 2 emergency room visits in the past for my kidney stones, which tend to be enormously painful. Both cases, they gave me some morphine, and wow, I was in great shape. What Michele was saying, they don't want to take narcotics on their cars, but is there something that you can do that at least will help on pain?
The most we can do is Toradol. So we're definitely not giving you morphine. If you are in that much pain, you need to go to the ER.
Now, do you guys, if you go into somebody's home and you realize looking around that social services could help this person,
That's a great question.
pick them up with, the Department of Human Services or anybody else like that?
So we are looking at, our goal is when we walk into the home, if this patient is trying to truly stay out of the ER, how can we help them stay out of the ER in the next few weeks? So do they have food insecurities? Do we need to set up Meals on Wheels for them? We're looking at, do they need a ramp to be built? Can we connect them with a service that's local in the area that can do that so they can get out to see their PCP? If we realize this person is a fall risk, we need to bring in home health to do a fall prevention program. Or even home health a lot of times has their own social workers. So they can do an even deeper dive into all the things that can help, making that recommendation. We won't follow the patient for home health, but we can write the order, get the process started, and then tuck it back in with the PCP so he can do his job. Great question. Yep.
So you said there were other similar services starting to crop up all over the place. Are there other competitors in the Northern Virginia area?
So I have not met a competitor yet, at least not one that can do to the extent of what we can do. But I do know of a mobile dental service that's looking at launching in your area in the next few months. They've got PCPs now that are rotating and going into the patient's home if you have a really hard time of getting out. It's really amazing the things that we have come up with, especially during COVID. These are needs that need to be met, and how can we do that? And so the businesses that have cropped up have been really, really breathtaking.
Are the people who come considered traveling nurses or something
So,
like that category?
So, good question. Our nurses actually are remote and they are part of that onboarding process. So there's not a nurse that's going to come out into your home. We have a APP, which is that advanced care professional. So your nurse practitioner or physician's assistants that would come out. We don't really have a special name for them. We just keep their regular titles.
If a person has an underlying condition like cancer or COPD, would you still come see them for something like flu, or would their pre-existing condition cause you to automatically send them to the ER?
No, we may dive a little bit deeper just to make sure there's not other things going on that we need to send you into the hospital for. But no, we will see if you have cancer and just need IV fluids or COPD and having an exacerbation. We'll dive a little bit deeper to make sure that it's truly safe for you to wait for us.
Okay. So we are about 10 minutes to 11. So Michele, if you've got any specifics that you haven't gotten to yet, that you'd like.
Pat has a question.
Yeah, only 2 cars with overlapping hours doesn't seem like a lot. Are you have plans to add more?
We do. We have plans to grow, and we're watching to see what that demand looks like. If you call in at the end of the day and we're already booked, we'll offer you an appointment for the next morning if it's safe. And so we're looking at how often does that happen? Should we go ahead and start planning to add a car? And the team that looks at that, they're geniuses. I'm so glad that I don't have to worry about that, because they've got this algorithm of, okay, now it's time to add that other car so we can meet the demand in the market. So as we continue to grow, we will add more cars, I promise.
Hey, Mike, you have a question?
I do. There was a third trip that I made to the emergency room. And what was happening was I had some bizarre drug interaction. My normal medicine was driving me crazy. And my symptom was, I call it buzzing. It was a strange thing where I really could not think or walk very well. And I needed some help. And so the idea was to get into the emergency room and hopefully they could figure out what was wrong. And they gave me some kind of a palliative, and it took a while. And then it had reduced enough. After I went home, I stopped those medications. But it was that kind of diagnostic. Something horrible is happening to me. I can't stand it anymore, waiting around, and I need the emergency room.
So if you called in and gave us those symptoms, we would dive just a little bit deeper in and then make sure that either we could come out to see you or that you needed to go to the hospital. So it would just be real specific to what was going on in that moment.
Michele, is Dispatch Health a standalone private company, or are you part of a larger corporate entity?
No, we're a private company. People ask me all the time, can I get stock in your company? No, it's privately owned.
No, I ask because, if you were owned by like a big pharmaceutical company, people might look at you in a very different way than if you're, an independent
Yeah.
operator.
We were
thought
started
you-
by Dr.
I thought you
Prather.
had some affiliation with Inova.
So we do partner with hospital systems, with insurance companies in certain areas. So if an insurance company says, hey, we have a really big problem with ER utilization, unnecessary ER utilization, will you come to this market and help reduce that? Or if the hospital system says, we need help offloading patients from the ER, or we know that this area really needs an extra help with that ER utilization, or we don't have a lot of primary care doctors because our growth has been so big. Please come out and help offload that. So there's all kinds of different partnerships that we have throughout the country where these healthcare entities have decided this is a good partnership to help reduce that ER utilization. We'll partner with them, but they don't own us and we don't own them. And that's kind of how that relationship works.
Do you get cases of dealing with people that are having mental health issues?
Oh, good question.
Deal with them.
So confusion will always trigger a secondary screen because we're going to dive in and see, is this a UTI situation, which, we can treat, or is this a mental health situation, which we can't? So you have to remember, we have two people coming into a home and we don't want to put them in a dangerous situation either. And so if it is a mental health situation, we're going to send them to the ER.
You showed all sorts of different services that you offered, and you said, but here in Northern Virginia, we're only doing the care portion of it. Mm-hmm. Are you going to add some of those services, and what's coming online next?
So that'll depend on growth and then what insurance coverage looks like. So we want to give everybody all the service lines. Mm-hmm. It'll just depend on how that path looks for this particular market with insurances and growth.
One more quick one, if I could.
Okay.
This business about the background information, and you said, I gotta do it every single time because otherwise the information may change. Now, of course, at 80 years old, I've had the same information for a long time. And but I keep giving it every time I change a doctor or something. There ought to be a way to have data source that is updated on a regular basis, then you can trust. And you can say, and do you have a so-and-so? And they give them your number and there you go. We need it. Apparently we don't have it, but it'd be nice to have.
So once you do call in and we treat you once, your information is in our system. So we will verify that it's all the same. You'll want to make sure to have your insurance card out so you can give us the number so we can just double check it. But once you give it to us, it does live in our system. We just need to verify. And you may be at your daughter's house for Christmas and feel really sick and not come home for a few days, and we see you at your daughter's house instead of going to your home. So there's all kinds of different situations. We want to make sure, since we're coming to you, that we have the correct information. Yeah. So in the event that you have a question that pops up in your mind, please reach out to, Carolyn, anybody in leadership over here, and you can ask that question. They have my direct contact, so they can reach out to me and get an answer for you.
Did we ask you if we could have a copy of the slide deck?
Yeah, I can send that to you.
That'd be lovely. Thank you. We can keep that in the office then.
Okay.
For anybody who wants it. All righty. Any other questions? Going once, going twice. Oops, what did we have? Oops.
Thanks for keeping the jargon to a minimum. And thank you very much for the time, info, and for the service itself.
Yes, thank you very much. I think we've learned a lot. As I said, I could have used this a few weeks ago and I knew about it by then. So
I
just
always
wasn't
get that
thinking.
when I present, like, I wish I had known a week ago.
Yeah. My husband wishes I had remembered a few weeks ago. Anyway, thank you so much, Michelle. We really appreciate you taking the time and talking with us this week.
Thanks for having me. Y'all have a great week.
Okay. Bye-bye, everybody.